This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alera, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled How I Do It, Microvascular Decompression for Vago-Glossopharyngeal Neuralgia. The lead author is André Brinzou from the University of Lyon.
This is a great technical note-style paper. Glossopharyngeal neuralgia, or GN, is something we don't see every day. In fact, the paper reminds us just how rare it is. While trigeminal neuralgia accounts for about 80 to 90% of facial pain syndromes, GN represents only 0.2 to 1.3%.
Exactly. And the authors make a point to call it Vago-Glossopharyngeal Neuralgia, or VGN, because the vagal rootlets are so often involved. When medication fails, microvascular decompression, MVD, is really the gold standard for durable treatment.
Right. Before we get into the how-to, let's talk anatomy, because that's where the vago part of VGN comes from. Ilera, how do the authors describe the rootlet arrangement?
It's a very intimate arrangement in the post-olivary sulcus. The glossopharyngeal nerve, CN9, usually has 1 to 4 rootlets emerging from the rostral portion. Right below that, the vagus nerve, CN10, arises from a longer series of 8 to 10 rootlets. They all converge toward the jugular foramen to enter the pars nervosa. Because they are so close, a neurovascular conflict, usually from the posterior inferior cerebellar artery, or PICA, often hits both nerves at once.
And that's why the clinical presentation can be so complex. Now, the paper emphasizes a very specific preoperative workup. It's not just about the MRI, is it?
No, they highlight 2 critical consultations. First, an otolaryngology consult is essential to rule out local pathologies that might mimic GN. They also want a baseline auditory evaluation, but interestingly, they also require a systematic cardiac evaluation.
Because of the syncope.
Exactly. GN can be associated with syncopal episodes, so the cardiac workup is a safety priority. On the imaging side, they recommend high-resolution MRI with T2-weighted CISS, Fiesta, or drive sequences. They also suggest T1 post-gadolinium to see the veins and 3D time of flight, or TOF, to characterize the arteries. They even mention fusion imaging to really pin down the conflict.
Let's move into the OR. For anesthesia, they are proponents of TIVA, total intravenous anesthesia, usually propofol and rimifentanil. As for monitoring, what's the protocol there?
They monitor the lower cranial nerves, so they restrict neuromuscular blockade to the induction phase only. They also mention that brainstem auditory evaluations, or BAPs, are helpful, especially during the surgical learning curve.
Now, let's talk about the how I do it part, the positioning. This is often where the success of the exposure is determined.
They use the lateral decubitus position, but there are some specific nuances. The patient is rotated slightly backwards so the shoulder falls toward the surgeon. They place a back support at the inferior tip of the scapulae and elevate the torso about 10 degrees to facilitate venous return. And the head fixation? 3-pin head holder, 1 pin above the ipsilateral eyebrow and 2 on the contralateral occipital bone. The head is slightly flexed. They actually specify keeping the chin approximately 2 finger breadths from the sternum to prevent venous obstruction. They rotate the head contralaterally and use a slight lateral flexion to keep the shoulder from obstructing the surgical corridor.
That shoulder is always the enemy in these low cranial nerve approaches. They even mention using a strap to pull it caudally, though they caution against excessive brachioplexus traction.
For the incision, it's planned posterior to the auricle, inferior to the asterional region, and extending toward the mastoid tip. This sets up the caudal retrosigmoid craniectomy.
I liked their note on the great occipital nerve. They prefer to mobilize it rather than section it to avoid postoperative neuropathic pain. That's a nice clinical pearl. Once they are in, they describe a keyhole retrosigmoid craniectomy at the level of the mastoid tip. How much of the sinus do they expose?
They expose the edge of the sigmoid sinus as caudally as possible, over a 3 centimeter length. They also remind us to occlude any opened mastoid cells to prevent CSF leaks. The dura is opened in a curvilinear fashion and reflected toward the sigmoid sinus.
Now we are in the arachnoid space. This is the infrafloccular approach.
Right. The first step after the dural opening is releasing CSF from the cisterna magna. That's vital for cerebellar relaxation. Once that's done, they place a self-retaining retractor, specifically Sujita blades, which are narrow and malleable, on the lateral surface of the cerebellar tonsil. They stress using minimal pressure.
The goal is to create a corridor beneath the flocculus toward the retroolivary sulcus. What are we looking for once we get there?
We are looking for the neurovascular conflict. The paper notes that the culprit is most often PICA, but it's not infrequent to see a compressive megaloligovertebrobasilar artery involved as well.
And the surgical instruments? They seem to stick to the classics.
Yes, bayonet scissors for sharp dissection of the arachnoid, and fine bipolar forceps for hemostasis to minimize thermal spread. They use a dissector probe to mobilize the vascular loops away from the 9th and 10th rootlets.
And for the decompression itself?
They primarily use polytetrafluoroethylene, Teflon. It can be shredded or knitted depending on the situation. They also mention polyester Dacron as an alternative, though it's more rarely used. The goal is either vessel transposition or Teflon interposition to relieve that conflict at the root entry zone.
The paper emphasizes that this infrafloccular approach through the cisterna magna allows for safe exposure of the lateral medulla and the root entry zone of the lower cranial nerves. It's about getting that specific angle to see the 9th, 10th complex clearly.
It really highlights that while the procedure is similar to a trigeminal MVD, the stakes with the lower cranial nerves and the proximity to the brainstem centers for blood pressure and heart rate make the vago part of the VGN complex something you have to respect.
Absolutely. The systematic cardiac evaluation they mentioned earlier is a testament to that. If you're manipulating rootlets that can trigger syncope or bradycardia, you want to know the patient's baseline.
To wrap up, the authors conclude that when a neurovascular conflict is demonstrated on high-resolution MRI in drug-refractory patients, MVD is the most effective therapeutic option. This step-by-step technique aims for optimal efficacy while maintaining a high safety profile.
It's a very clean, concise guide. For our residents listening, the key takeaways are the specific positioning, that 2-finger chin to sternum rule, and the importance of the infrafloccular corridor.
And don't forget the ENT and cardiac clearances.
Essential. Well, that's all the time we have for today's deep dive into vago-glossopharyngeal neuralgia.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you next time.